This morning, we are going to talk about development and congenital malformations of the digestive system. It's a slightly longer lecture, but I've tried to focus on what is key so that we are able to still use as minimum time as possible, yet cover as much as we can. Before we talk about the development and congenital malformations of the digestive system, perhaps it is important that we familiarize with what you're going to develop. In terms of anatomical components of the digestive system, we can categorize these components into two. The hollow GIT refers to the path that is followed by food. This is what we commonly call the alimentary canal or the gut. The second component would be the extrinsic organs of the digestive system, which refers to the different organs that provide their secretions into the lumen of the digestive system, yet the organs are not found within the wall. So this refers to the salivary glands, pancreas, liver, and the gallbladder. Just to review the components of the alimentary canal. So remember, food enters the oral cavity, then goes to the pharynx. In this lecture, we are not going to develop the oral cavity and the pharynx because these ones are done when you're doing the pharyngeal apparatus. But from the esophagus downwards, you're going to develop. So we'll look at development of the esophagus, development of the stomach, development of the small intestine. And remember, small intestine, we are starting with the duodenum, jejunum, then ileum. Then we look at development of the large intestine. And when you talk of development of the large intestine, when you talk of large intestine, we are referring to the cecum, the appendix, the colon, the rectum, and the anal tube. So this is the path followed by food. Well, we know that food does not go to the appendix, but it's part of the large gut. Also to remind you that the wall of the digestive system has 4 histological layers: mucosa, submucosa, muscular layer, and the adventitia. In as much as there are those 4 histological layers, I want you to look at them in terms of the tissues. And if you look at them in terms of tissues, then we can say that we have epithelial tissue. The epithelium forms the epithelial lining as well as the glands within the wall. They could be submucosal glands, they could be mucosal glands. Then the second entity is connective tissue. Remember, connective tissue is within the lamina propria as well as within the submucosa. The third entity is the muscular tissue, which could be part of muscularis mucosa or part of muscularis propria. And the last entity is neuronal tissue. The neuronal tissue is part of the enteric nerve plexus. So being found within the submucosa, that's the submucosal plexus of Mesenus, or it can be found within the muscular layer, and that's the mesenteric plexus of Albach. So look at them in terms of the tissues, because when you're going to do the embryonic origin, we'll be focusing on the tissues rather than the histological layers. So in this lecture, what do we need to learn? We need to know, first of all, we will review the process of embryonic folding and state the effect of embryonic folding on the yolk sac. How does embryonic folding influence the yolk sac? After we address that, we will outline the embryonic origins of the different tissues and organs of the digestive system. After we've done that, we will look at the parts and derivatives of each part of the primordial gut. That will be more of laying foundation to the storyline. Then now in particular, we will pick some segments of the alimentary canal that we will develop. I told you we will not focus on the mouth and pharynx because that one is already done. Right now you can be asked to develop, you can be asked to state the origin, development, and congenital malformations of the mouth or the pharynx, and you can do that very well. How about the esophagus, the stomach, and the intestines? We've not yet done those ones. So today we are going to do those ones. Then there's something called the cloaca. I know you've talked about the cloaca when you're doing urinary system. We will also talk about it when you're doing reproductive system. And we are also going to talk about it today, now that you're doing the gut. We will in particular look at how the cloaca is partitioned and the congenital anomalies of the cloaca. Lastly, we will talk about embryonic origins and malformations of the hepatobiliary system. In this case, we'll be focusing on the liver, biliary tree, and the pancreas. So that is the roadmap. Let's focus on the first agenda, embryonic folding and its effect on the yolk sac. So we know that the embryo folds in two axes. There is folding in the transverse axis, that is also called the lateral folding. And there's folding in the sagittal plane, which you also call the craniocaudal folding. At some point, we went through embryonic folding. And I've shown you these videos before, but I'll do it again today. So the first video I'm going to play is a video showing you the process of embryonic folding in the transverse axis, folding in the lateral. Lateral embryonic folding. So let's look at that. You now have the trilaminar embryo with blue being ectoderm, that the color being mesoderm and the yellow being endoderm. The green is not occurred. So we can see in these images that the ectoderm is trying to fold to undergo the process of neurulation at this point. So neurulation is taking place. That is primary neurulation. So that you'll have a neurotube and perhaps Neuro Crest and the surface ectoderm. But pay attention to the mesoderm. The mesoderm is dividing into three segments at this point. I hope you remember the names of the three segments of the interembryonic mesoderm. Also pay attention to the endoderm. We can see the three segments of the mesoderm: the paraxial mesoderm, the intermediate mesoderm, and the lateral plate mesoderm. So far, the transverse folding has not taken place. I hope you've realized. All those things which have happened are not because of transverse folding. Neurulation is not a result of transverse folding, and you see it's almost complete. We can see the neural groove forming there. Now, transverse folding now wants to begin. And look at how it's happening. Look at the impact of the transverse folding on the Yoxa. The Yoxa is shrinking, it's becoming smaller, with some part of it being incorporated into the embryo. Look at the shape of the embryo. It has now become cylindrical instead of that flat thing. Let me take it back a bit somewhere there so that you look at that again. The amnion is expanding. This region here, this space here between the lateral, between the two layers of the lateral plate mesoderm, somatic mesoderm and splanchnic mesoderm, you can see that space there is forming. So there are a number of outcomes of the transverse embryonic folding. We can talk about expansion of the amniotic sac. We can talk about incorporation of the yolk sac into the developing embryo. Now, which part of the yolk sac is incorporated? The dorsal part of the yolk sac is the one that is incorporated into the developing embryo, the part I'm pointing at right now. That dorsal part of the yolk sac, which is incorporated into the developing embryo, is the one that's going to form the primitive alimentary canal or the embryonic gut tube. The ventral part of the yolk sac, this one, is not incorporated into the embryo. This part is going to disappear. It will involute. At this point, it has not yet involuted. And as we can see, it has a connection with the embryonic gut tube. The connection between the yolk sac outside and the embryonic gut tube is called the yolk stalk, or commonly called the Vitalin Duct. So this is the Vitalin Duct. The other outcome of the transverse folding is we can see now the interembryonic coelom is being incorporated in the baby. And this is what is going to become the body cavities: peritoneal cavity, pericardial cavity, and the pleural cavity. This is where the cavities come from. And that's why the two layers there will form the layers of those mesothelia, the pleura, peritoneum, and pericardium, the serous pericardium for that matter. Look at the shape of the baby. The baby has become cylindrical instead of flat. That is transverse embryonic folding. Of importance is that the dorsal part of the yolk sac has been incorporated into the embryo to form the primitive alimentary canal. The ventral part is outside. The connection is called Vitalin duct. Let's look at folding in the craniocaudal axis. So that is the second image there. So you see this large thing here. This is the embryo. The trilaminar embryo is there with ectoderm, mesoderm, and endoderm. This is the amniotic sac, and that's the yolk sac. This is the allantois. That's the connecting stalk. This is the chorionic cavity. If this is the connecting stalk, it means that this is the splanchnic layer of extraembryonic mesoderm, that the somatic layer of extraembryonic mesoderm, followed by cytotrophoblast, the one that's giving you the villi, and external to that, you can see syncytiotrophoblast. Therefore, this is the chorionic plate, somatic layer of extraembryonic mesoderm, cytotrophoblast, and syncytiotrophoblast. This is the chorionic plate, and that is why this is the chorionic cavity. Coming back to the baby, you know, this is where the heart is developing. At some point, the heart is above the future brain. But as you're going to see in this folding, the heart is going to descend to the thorax. I believe you did development of the heart and you talked about the mechanisms of cardiac looping. Okay, follow this one now. See what's happening to the Yoxa and see what happens to the amniotic cavity. So not yet folding. Now it's beginning to fold and see what happens. The heart goes down. See what happens to the Yoxa. The distal part of the Yoxa is being incorporated slowly into the baby. The ventral part of the yolk sac is remaining outside. The connection between the two is the Vitalin Duct. So this is the yolk sac that has been incorporated to form the embryonic gut tube. This is the yolk sac outside. This is the Vitalin Duct. Look at the other results of the craniocaudal folding. The heart has descended to the thorax. The brain has become cranial. The baby has curved. This is what you call the fetal curvature. The amniotic sac has expanded. The umbilical stalk has been formed, among other results that we may have talked about sometime last semester. So just to then bring the storyline into some static images, that's the yolk sac with its lining, the endoderm. This is the mesoderm, so paraxial, intermediate, and lateral plate mesoderm. I want us to focus on the lateral plate mesoderm. It has somatic layer and splanchnic layer. As the yolk sac is being incorporated, see what happens. So that you incorporate the gut tube into the baby, we will see that the gut tube is lined by endoderm inside, followed by splanchnic mesoderm outside. I want you to note that because that's going to have implication when in understanding the embryonic origin of the tissues of the digestive system. Endoderm is inside, followed by splanchnic mesoderm. And then that becomes the cavity. This is the yolk sac. In the craniocaudal axis, yolk sac has been incorporated, as you've seen in the videos. You can see it's becoming smaller as time goes by. The connection is the Vitalin Duct. We are done with the first agenda. During embryonic folding, the yolk sac is incorporated into the baby. It's the dorsal part that is incorporated. The ventral part is outside. The connection between the two is known as the Vitalin Duct. Let's address the second agenda, which is embryonic origins of the tissues and organs of the digestive system. So, having said that the gut tube is lined by endoderm inside, as you can see in these transverse folding images, that's the endoderm, this is the splanchnic mesoderm. And then as development, as folding continues, this is how it becomes. So that's endoderm. The most inner layer is the endoderm layer. So by all means, the endoderm must participate in the formation of the different tissues of the digestive system. In particular, endoderm gives rise to the epithelial lining of the gut wall. So think about the epithelium, where the epithelium of the esophagus, that of the stomach, of the intestine, the epithelial lining of the gut wall, whatever type of epithelium it is, it comes from endoderm. The second thing endoderm will give rise to are the exocrine glands of the digestive system. Whether these exocrine glands are intrinsic, like gastric glands, Brunner's glands, the intestinal crypts of Lieberkühn, whether they are those intrinsic glands or they are extrinsic, like the biliary system, the liver, whether they're intrinsic or extrinsic, pancreas, they arise from endoderm. So the glands come from endoderm. That means that there are endodermal outgrowth. The extrinsic ones are endodermal outgrowth from the wall of the yolk sac. Oh, that's endoderm now. But let's look, we will see that the tissue immediately outside endoderm is splanchnic mesoderm. So again, by all means, the splanchnic mesoderm must also contribute to formation of the digestive system. What exactly does the splanchnic mesoderm give rise to? In this image, we see the splanchnic mesoderm immediately outside the endoderm. And so it has to give rise to something. Splanchnic mesoderm gives rise to connective tissue elements of the digestive system. So it could be the lamina propria, or it could be the submucosal. Whatever it is, it comes from splanchnic mesoderm. Apart from that, the splanchnic mesoderm also gives rise to the smooth musculature. Could be the muscularis mucosa, or it could be the muscularis propria, or otherwise known as muscularis externa, come from splanchnic mesoderm. The mesentery comes from splanchnic mesoderm as well. Remember, the mesentery is the double layer of the visceral peritoneum. So the mesentery also comes from splanchnic, and we can appreciate that here. This is what will become the mesentery. This is of splanchnic mesoderm origin. The third entity that contributes to development of the digestive system is the Neuro Crest. In as much as we rarely talk about it, is very important. Remember that when neurulation occurs, there are two types of neurulation, primary neurulation and secondary neurulation. When the primary neurulation process takes place, we have formation of the neurotube and the Neuro Crest. The Neuro Crest cells have a number of characteristics. They are multipotent cells, they are migratory cells. If we look at that second property, they are migratory. Neuro Crest cells indeed migrate from where they are, they invade the developing gut tube. This migration and invasion process is organized. Usually, it is from the cranial sides of the gut towards the caudal parts of the gut, which means if you are assuming the migration would then be moving from the esophageal end towards the rectal end. The cells migrate. Now, we don't have to take it vaguely like that, that actually the cells that are in the rectum must have entered through the esophagus, not necessarily. But that at least the cells will have migrated into the esophagus before they migrate into the rectum. That is more appropriate to assume. Okay, so with that in mind, therefore, you expect that if there was something that was going to arrest migration of Neuro Crest into the GT, then we would expect the lower parts of the gut to be the ones that are more affected than the cranial parts of the gut. Have that back in your mind somewhere. The Neuro Crest, which migrate into the GIT, give rise to the enteric nerve plexus. So remember that the enteric nerve plexus, we have the mesenteric nerve plexus, which is found within the muscular layer, and this one controls GIT peristalsis. We also have the submucosal nerve plexus. The submucosal nerve plexus is found within the submucosa, as the name suggests, and this one controls GIT secretions. It is argued that the Neuro Crest cells may also contribute to formation of the cells of the DNS. The cells of the DNS are the cells of the diffuse neuroendocrine system. Now, we have a number of cells of the diffuse neuroendocrine system in the wall of the gut. It is argued that they could be of Neuro Crest origin. What do these cells do? Cells of the DNS produce hormones. So give them different names depending on this hormone they produce. Some time back, we talked about two of them, the G cells, which produce gastrin, the D cells, which produce somatostatin. We can still have other cells, the K cells, which produce cholecystokinin, the S cell that produce secretin, and the like. There are several cells. And therefore, there are several hormonal substances which these cells can secrete. Indeed, it is argued that if you are to bring all the cells that produce hormones, the cells that produce hormones which are embedded within the digestive system, if you are to bring them all together, they would perhaps form the largest endocrine organ in the body. And so for that reason, some people prefer to call this the gastroenteropancreatic endocrine organ. The gastroenteropancreatic endocrine organ could be coming from Neuro Crest cells. Okay, if you forget about that, not a big deal. At least remember that the enteric nerve plexus come from Neuro Crest. And when you talk of enteric nerve plexus, we are referring to the mesenteric plexus as well as the submucosal nerve plexus. I'm looking for that submucosal plexus in here and I'm not seeing it. Okay, but at least I believe you remember. Okay, it's here actually, there. The submucosal nerve plexus and the mesenteric nerve plexus. Okay, that was the second agenda. So we now know where the different tissues of the digestive system come from. Now that storyline I've just given you is an important one. If somebody asks you to talk about development of any part of the gut, it is important that you bring that foundation first. Even if I ask you to develop the rectum now, I would expect you to tell me the embryonic origin of the tissues of the rectum. And so it's a standard gospel. The epithelium of the rectum come from endoderm. The muscles of the rectum come from splanchnic mesoderm. The nerve plexus in the rectum come from Neuro Crest. Don't think about it too much. That statement that I've given you applies for the segments of the GIT we are going to talk about. And so it is something you can replicate in any organ. Even if I ask you tomorrow to tell me embryonic sources of the duodenum, your answers will be the same, as long as you're talking about the tissues. But there is something else that we need to highlight that will make a difference between embryonic origins of the different tissues. And that's our third agenda here. So in this third agenda, I want us to look at parts and derivatives of each part of the primordial gut. We have seen that the primordial gut is the part of the yolk sac that has been incorporated into the embryo following embryonic folding. This part of the yolk sac is known as the primordial gut. The primordial gut is described to have 3 segments. The segment that retains connection with the yolk sac is called the midgut. The segment cranial to the midgut is called the foregut, and the segment caudal to the midgut is called the hindgut. Of importance is that the hindgut also has connection with the allantois. The connection of the hindgut with the allantois is known as the cloaca. So remember that there are 3 segments of the primordial gut: foregut, midgut, and hindgut. Our objective is to talk about the derivatives of each part of the primordial gut. Let's start with the foregut derivatives. Now, the foregut has a number of derivatives. There are some foregut derivatives which are part of the alimentary canal, and that's what I'm calling the gut. So in terms of the gut, foregut gives us this segment extending from the pharynx to the duodenum, which means what? That the pharynx is a foregut derivative. After pharynx, it is the esophagus. The esophagus is a foregut derivative. After esophagus, we go to the stomach. So the stomach is also a foregut derivative. After stomach, we talk about the duodenum. The duodenum is a foregut derivative. However, you need to put a comma there. Only the proximal part of the duodenum is a foregut derivative. The distal part of the duodenum is not within the foregut. So the question then arises, what's the junction between the foregut and the midgut segment? Remember, duodenum has 4 parts: D1, D2, D3, and D4. The junction between foregut and midgut is somewhere within D2, the lower parts of D2. That means that D3 and D4 are not foregut derivatives. D1 is a foregut derivative and a large part of D2. Okay. Apart from the gut, okay, so this image shows you the extents of the foregut. So the pharynx, esophagus, then stomach, and then the proximal part of the duodenum up to somewhere there, just below the opening of the major duodenal papilla. And remember, the major duodenal papilla empties at D2. So just below that, that is the extent of the foregut. In terms of the extrinsic glands, foregut still gives you something. Foregut gives you the liver, the pancreas, and the biliary tree. These are foregut derivatives. So they come from the endoderm of the foregut. Perhaps at this point, it's important to mention that the mesentery behind the stomach has some mesenchyme there. The mesenchyme behind the mesentery of the stomach is also where the spleen will come from. Now, I'm mentioning this because when you look at blood supply to the foregut, which is a celiac tree, the spleen also derives its blood supply from the celiac trunk. And you ask yourself why? It's because embryologically, it's closely related to foregut development. And that's why the celiac tree or the celiac axis gives you the splenic artery to the spleen. That is not to say that spleen is a foregut derivative. Not quite true. Okay, other than the GIT, the foregut also has another origin, another derivative, and this is the lower respiratory tree. So remember that it develops the lower respiratory system from the larynx downwards. So larynx, trachea, bronchi, and indeed the rest of the bronchial tree and the lungs included come from the foregut. It was a bit discouraging to ask some of you during the vivas to just tell me the steps of development of the respiratory system, the stages of lung development, and people have no idea what that is. You've already done the development of the respiratory system. We expect you to know. Anyway, these are the derivatives of the foregut. In particular, I want you to remember that foregut gives you digestive system as well as respiratory system, because there are some malformations of the foregut which revolve around that concept. How about midgut? The midgut segment extends from just below the opening of the major duodenal papilla in the duodenum all the way to somewhere at the junction between, somewhere within the transverse colon, either between the middle of the transverse colon to the junction between the right 2/3 and the left 1/3 of the transverse colon. So somewhere there. Which means what? In terms of derivatives, the midgut gives you both the small intestine and the large intestine. The segments of the small intestine that come from the midgut are the distal part of the duodenum, which means from that small distal part of D2, then the whole D3 and D4. Then the whole of the jejunum and the whole of the ileum, they all come from midgut. And it doesn't end there. Midgut also gives you the large gut. So if you're to trace, perhaps D2 ends somewhere there, then maybe D3 and D4, then maybe jejunum and maybe ileum. Then we start the large gut. So perhaps cecum and appendix, ascending colon, then we start the transverse colon. As we start the transverse colon, we will only take the right half to 2/3 of the transverse colon. That is the far much that the midgut can extend. Those are the midgut derivatives. Then hindgut derivatives will then extend from that point, which means either from the middle of the transverse colon or the distal 1/3 of the transverse colon. Hindgut extends from there. Then we go to the descending colon. We go to the sigmoid colon. We go to the rectum and anal tube. Of importance is that when we reach the level of the rectum and the anal tube, those segments are actually incorporated within the cloaca. So this cloaca will have to undergo partitioning to split the urogenital system from the digestive system, so that those last two parts that I've mentioned, the rectum and anal tube, in as much as the derivatives of the hindgut, they will come into vision after the cloaca has been partitioned. The cloaca gives you the rectal segment and the anal segments of the hindgut. Okay, that summarizes the story of the embryonic origin of the digestive system in terms of the tissues of origin. This shows you the cloaca there, which is a common union for the hindgut and the allantois. Before I give you a short break, perhaps we summarize a story here of the vascular territories of the three different gut segments. The artery of the foregut is the celiac artery. The artery of the midgut is the superior mesenteric artery, and the artery of the hindgut is the inferior mesenteric artery. They are all anterior branches of the abdominal aorta. So remember that the celiac artery gives you branches which go to the stomach, spleen, liver, pancreas, duodenum, and even lower esophagus, because all those are Foregut derivatives. Similarly, the superior mesenteric artery gives you branches which go to the duodenum, jejunum, ileum, appendix, ascending colon, and transverse colon, because all those are midgut derivatives. And lastly, inferior mesenteric artery gives you branches which go to the transverse colon, descending colon, sigmoid colon, and the upper rectum, because again, they are hindgut derivatives. So the three arteries of the gut are territorial based on the embryonic origin. But of importance again is to note that the regions where these three arteries anastomose represent regions which have dual origin in terms of the gut segments. The duodenum is supplied by both celiac artery and SMA because it arises from foregut and the midgut. The transverse colon has an anastomosis around it, which we call the marginal artery of Drummond. Now, this is also because the transverse colon has dual embryonic origin in terms of the segments. It's a midgut derivative as well as a hindgut derivative. Okay, I want to give you a short break. We've done about 40 minutes. So I'll give you a short break. Let's just have a 5-minute break. So it is now 8:21. I'll give you 5 minutes break after I've taken a few questions. If you do have, let me first enable your mics and allow you to ask questions. We can now resume now. We are going to now look at development of specific segments of the alimentary canal. We will start with the esophagus, then look at the stomach, and then the intestines. So, in terms of development of the esophagus, remember what I told you before this, that the esophagus is a Foregut derivative. So that the site of origin, Foregut. But I also told you the tissues of origin of the GIT, esophagus included, about the endoderm giving you epithelial lining and glands. Mesoderm, spiked mesoderm gives you smooth musculature and connective tissue, and Neuro Crest giving you the nervous system. Okay, so that still stands. But now, in terms of the sequence of development, what do we need to talk about? The first thing that must happen in the foregut is formation of the respiratory diverticula. You may have given it some different names. Laryngotracheal groove forms, then now outpoaching, whatever you call it, bronchial bud, I don't know what you call it. But there is something that forms in the ventral aspect of the foregut as an outgrowth. It marks the formation of the lower respiratory tree, the tracheobronchial tree. So we call it the respiratory diverticulum. This respiratory diverticulum grows away from the foregut. As it grows away, it needs to be separated from the foregut so that we can separate the digestive system from the respiratory system. The process of separation occurs by formation of some ridges between the respiratory diverticulum and the remaining foregut. Those ridges are known as tracheoesophageal ridges. There's a right and a left ridge which grow towards each other, tracheoesophageal ridges. We call them so because they mark the separation between the trachea and the esophagus. The tracheoesophageal ridges grow towards each other and form a septum. The septum they form is known as tracheoesophageal septum. So the tracheoesophageal ridges develop towards each other to form tracheoesophageal septum. Then the septum fuses, and after the septum has fused, you've separated the trachea in future from the esophagus behind. That septum does not form completely upwards. It will leave a small entry to the trachea. And that small entry upward is what we call the laryngeal inlet. I saw someone's hand, but she is lowered. I believe you're sorted. We can continue. Okay, so I want you to understand that the foregut undergoes septation process by formation of the tracheoesophageal ridges, which fuse to form tracheoesophageal septum, but the septum is not complete because you need to have some gap for the laryngeal inlet. After the septation, what is in front is what we call the trachea, and what is behind is the future esophagus. So then what happens to the esophagus? The esophagus at this point is very short, so it must undergo elongation. The process of esophageal elongation is facilitated by the craniocaudal embryonic folding. So this is one of the results of craniocaudal embryonic folding. It causes elongation of the esophagus. And this is particularly because as craniocaudal embryonic folding is taking place, the heart is descending. And when the heart descends, what happens with the thoracic diaphragm? It's also pushed down. If the thoracic diaphragm is being pushed down, what happens in the stomach? It's also being pushed down. That makes the esophagus to elongate. There's another mechanism that explains esophageal elongation, but beyond our scope. Our scope is to understand that esophagus elongates during development. Think through something. So this is the esophagus that is supposed to elongate. But I want you to think through something. As we mentioned earlier, the endoderm is inside and the splanchnic mesoderm is outside. Endoderm is inside and splanchnic mesoderm is outside. On the first image on your left, you see that aspect. The yellow is endoderm. I don't know which color is that one. Is it blue? Let's call it blue. So the endoderm is inside, the yellow one. The blue is splanchnic mesoderm. Endoderm grows faster compared to splanchnic mesoderm. Remember, endoderm is epithelial. So the epithelial proliferates a bit faster compared to the mesoderm. What's the effect? Because of faster proliferation of endoderm, the lumen of the esophagus obliterates. That means that there's a time of development when the esophagus is just blocked. We call that the solid stage of development. So the solid stage of development comes about because of faster proliferation of endodermal cells. And that leads to obliteration of the lumen of the esophagus. This concept of solid stage is not limited to the esophagus, actually. It's a concept that is universal for anything that has endoderm inside and mesoderm outside. And so even in the respiratory tree, it was there. When we talked about those phases of development, you know, the embryonic stage, then the pseudoglandular stage, then canalicular stage. Why are we talking about canalicular stage? Because in the pseudoglandular stage, those branching airways are solid structures. Their lumen are obliterated. That's why the respiratory system must undergo the canalicular stage of development before we go to the terminal sac and alveolar stage. So the concept of solid stage applies to most embryonic structures that have endoderm inside and mesoderm outside. And the reason is because endoderm grows faster and so the lumen becomes obliterated. Esophagus, not an exclusion, which means even stomach or even the intestines will have this solid stage of development in as much as we may not talk about it. So remember that. We might not mention it again, but remember the concept is there. Having said so, the esophagus you and I have need to have a lumen. And for that reason, then we must have a process of canalization. So I call it recanalization because the esophagus had a canal before, then got obliterated, so the canal is reforming. I prefer using the term recanalization rather than the ones in the respiratory system, because the ones in the respiratory system, as the airways branch, they usually branch by the time they're already solid. And that's why we usually call that one canalicular stage. But this one is a recanalization. The esophagus must recanalize. Kindly remember those key steps of development of the esophagus. Respiratory verticulum forms, then there is septation of the foregut, then there's elongation, then recanalization because there was a solid stage at some point. Okay. So with that in mind, what are some of the congenital anomalies that we'd expect for the esophagus? One entity is what we call esophageal atresia and or tracheoesophageal fistulae. Why do we call them so? First of all, I want you to understand that these occur due to abnormal foregut septation. If you have abnormal foregut septation, you are going to have abnormal communication between the trachea and the esophagus. The abnormal communication between the trachea and the esophagus is what we are calling tracheoesophageal fistula. But you may also just have lack of tubular esophagus. What I mean is that the tubular lumen of the esophagus is not continuous. If you don't have continuity of the tubular lumen of the esophagus, we call that esophageal atresia. The term atresia means blocked. And if you have to just redefine it in a different way, blockage means that there is lack of continuity of the tubular lumen. So when we have esophageal atresia, it can be on its own, but it can also be together with tracheoesophageal fistula, or the tracheoesophageal fistula can be on its own. And because it's one spectrum, that's why we give it that complicated name, esophageal atresia and stroke or tracheoesophageal fistula. There are 5 different types of this entity. Let's look at the first one. In the first image, we don't see abnormal communication between the trachea and the esophagus. So we don't have tracheoesophageal fistula. However, we see some point of narrowing of the esophagus. We can conclude that to mean that there is blockage. So there is lack of continuity of the tubular lumen of the esophagus. Therefore, that is esophageal atresia. So in type A, we have esophageal atresia without tracheoesophageal fistula. That is type A. Let's look at type B. So in type B, we can see a fistula there, which is connecting the esophagus to the trachea. So that's a tracheoesophageal fistula. But we can also appreciate that the tubular lumen of the esophagus is not continuous. So this is esophageal atresia with a tracheoesophageal fistula. Now that there is esophageal atresia, we are interested to know whether the fistula is connecting the upper segment of the esophagus or the lower segment of the esophagus beyond the atretic segment. So this one is the fistula is on the upper segment. Now that's what we call type B. Type B is esophageal atresia with a proximal tracheoesophageal fistula. Let's look at type C. And type C is the commonest that I want you to remember at least. So type C is esophageal atresia. You now understand what that means. With a distal tracheoesophageal fistula. And let's look at type D. There is still esophageal atresia here. If you understood what I told you, that there is lack of continuity of the tubular lumen of the esophagus. So there is esophageal atresia with a double fistula. So there is both proximal and distal fistula. That's type D. And type E, there seems to be no esophageal atresia because the lumen of the esophagus is continuous. However, there is a fistula. So this is tracheoesophageal fistula without esophageal atresia. Let me jog your mind a bit and ask you with regard to type C. How do you think this baby in type C will present clinically when this baby is born? How do you think this baby will present clinically? That one I want to hear what you want to say. So just put up your phalanges and I'll enable your mic and you can give me what you think. What do you think will be the clinical presentation of this type C, tracheoesophageal fistula? Anyone? All right. Yes, Jerry.
There would be vomiting.
Okay, I get that. Anything else?
There would be a lot of air in the esophagus.
Okay, good attempt, good attempt. Is there anything else you want to add? All right, good. Anyone else to add to what Njeri has said? Yes, Yvonne. Yvonne, you need to unmute first.
They will be underweight.
Okay, fair enough. That's very true. Okay, someone else put up their hand but lowered it. Okay, let's debate on what you said. So, at the time of birth, and this goes back to Jerry, at the time of birth, we are saying that we have esophageal atresia, which means that food cannot really reach the stomach in the first place. So I know you said vomiting, but I want you to edit that because you can only vomit what is in the stomach. This one, food does not go down at all. And remember, the food you're talking about is breast milk. This is a newborn baby. So this child will not be able to feed. And if they feed, the milk comes back. The term we use is regurgitation. They'll be regurgitating food. So you don't want to use the term vomiting because it doesn't reach the stomach. Hope you get the concept. But remember that we constantly swallow saliva. Even babies do that. Now this baby will not be able to swallow saliva. So the saliva they produce will also just be coming back. They'll be having a lot of secretions in the mouth. So esophageal atresia will present with secretions in the mouth, whether type A or type C. They'll have a lot of secretions in the mouth, and then they will not be able to breastfeed. They'll be regurgitating milk. That is how they clinically present. And because they are not feeding appropriately, if this is allowed to go for long, really, and that shouldn't happen, But if this is allowed to go for long, it means that this baby will be malnourished. Now, this particular one, you really don't want to talk about that, because unless something is done, this baby is going to die. There'll be no entry for even giving time for malnourishment and then weight loss. But the point here is that, and this is with regard to what Yvonne said, that because they have difficulty in feeding, then they'll be having very low weight, they'll be underweight. The point here is that they'll be malnourished. But if you look at it carefully, if someone is not feeding at all, they may just die rather than actually waiting for malnourishment. But you still get the point that Yvonne's talked about. It's one of the indicators of children with difficulty in feeding. You've not told me, as with regard to this distal fistula, how this will present. Remember, this child is breathing. Air is going to the lungs, but it's also going to the stomach. So in as much as this baby is not feeding, the abdomen will just be distending, and the abdomen is full of air. It will be distending. Now, radiologically, when we do X-ray radiograph investigation of this baby, we may see air in the esophagus, and that is with regard to what Maureen said, that will be air in the esophagus, and that's true. That's a radiological finding. You'll also see air in the stomach, again, a radiological finding. I'm insisting on this one because the commonest, but in terms of academia, we can ask you how this one will present, how that one will present, how this one will present, how this one will present clinically. Just think through the way you look at that abnormal anatomy. For example, this one. The moment this baby breastfeeds, what happens? Will be very different from how this one breastfeeds. Very different. Dramatic, for that matter. This one, the moment they breastfeed, the milk goes to the lungs, then what happens? They just choke. So this one, the moment they start suckling breast, they'll start coughing immediately, and different from this one. So understand the concept well. Okay, I can see two people having questions. Watara, your hand was up first. You can go first.
I had a question about the newborns. Would they also present with complications of polyhydramnios, like pulmonary complications? And because they're not, yeah.
Yes, I get your point. Yeah, so that is usually one of the markers that a baby might be having esophageal atresia. Now remember, polyhydramnion is not a presentation of the newborn. Polyhydramnion is a presentation during pregnancy. So during pregnancy, before this baby is born, we'll be seeing polyhydramnions in the pregnancy. Then we start asking ourselves, what could be causing the polyhydramnions? Maybe there is esophageal atresia. Then now at the time of birth, we can confirm that one. These days, we can still try to confirm before birth, but the better one will be after birth to confirm. So before birth, you can only suspect. Then after birth, we can confirm on the baby. But yes, before birth, you'll suspect based on polyhydramnion. You are right. Jackie, you have a question. Carry on.
Okay, I think it's almost a similar question. Just wanted to find out, immediately after birth, is there cases whereby the child is born with a normal birth weight, but within now the 6 hours, the first 6 hours after birth is when we can identify the baby having the following congenital anomalies from their presentation after feeding? Because initially, through breast milk, but after birth, we're able to see within have an infant being born with the normal birth weight, everything is normal, apart from the fact that the moment they're being fed, now we identify the symptoms above.
Yes, you're right, Jackie. Actually, that's the most common presentation, that they might just be born and at the time of birth, everything is normal. Then now you start suspecting this the way they start feeding them. So in most cases, what you're describing is the most common clinical presentation. You don't suspect it until the first few hours after birth. Okay, Gayansi.
I have a question. Does regurgitation also take place in adults? And if it does, how does it take place?
Yes, regurgitation can still take place. To regurgitate just means to come back. That it simply means to come back or to bring back. So food can regurgitate, which means can go back. And usually in adults, we don't commonly talk about regurgitation. We use the term dysphagia, difficulty in swallowing. Okay, Maureen.
Sir, when the endodermal cells fill the tube and make it solid, is that the first step? Because this term recanalization means that it was a canal first, then it becomes a solid, then a canal again. But my understanding is that it's a solid, then a canal. So why this term of recanalization?
Right, that's what I explained, that we are using the term recanalization because remember, the yolk sac was luminal initially. And so the embryonic gut tube is luminal initially. That's why we are recanalizing. You know, this is different from respiratory diverticulum, because the respiratory diverticulum, the thing is outgrowing from the wall of the yolk sac. So for respiratory system, the thing is solid from the beginning. But for GIT, the yolk sac was luminal initially. Remember, it's a cavity, so it's a lumen initially. And then that lumen obliterates because of endodermal proliferation, then now recanalization takes place. All right, let's continue with the other anomalies of the esophagus. So you may have a situation where the esophagus does not elongate appropriately. If the esophagus does not elongate appropriately, you ask yourself, where will the stomach be? If we have inadequate esophageal elongation, it means that you'll have a short esophagus. And that means that the stomach will be pulled upwards into the thorax. So the gastroesophageal junction will be above the diaphragm. If that happens, we call that congenital hiatal hernia. So in congenital hiatal hernia, there's some parts of the stomach which are through the diaphragm into the thorax. It could be because of a short esophagus. There are other causes of congenital hiatal hernia, not within our scope. Lastly, we have talked about the concept of recanalization. If recanalization does not occur appropriately through that process of apoptosis, then you'd expect some problems. Either you can have a very narrow lumen, which we call esophageal stenosis. The term stenosis means narrow. So esophageal is just because this is esophagus. You may have some thin membranes in the esophagus, which we call esophageal webs. You may even have a cyst separate from the wall. We generally call those cysts foregut duplication cysts. Foregut duplication cysts. Great. Those are malformations of the esophagus. Now let's develop the stomach. So again, in terms of site of origin, remember it's a foregut. And in terms of tissues of origin, endoderm, splanchnic mesoderm, Neuro Crest. With the entities they give you, we have already explained that one. So I'll go straight to the sequence of development. Now for stomach, it begins by a swelling. That swelling forms in the distal parts of the foregut. The term commonly used in textbooks to describe that swelling is fusiform dilatation. It's a very smooth dilatation, fusiform dilatation. Now remember, it's just dilate fast. After the dilatation, the next step is this: that the posterior border of the future stomach grows faster compared to the anterior border of the future stomach. That has implication. The implication is that the stomach is going to form a curvature. The stomach is going to curve. Let's assume this. So I have something in my hand here, which is supposed to be called stomach by now. I believe you can see it. So let's imagine it's a tubular thing. This is our stomach. We are saying the anterior part grows faster compared to the posterior part of this stomach. Sorry, the posterior part grows faster compared to the anterior part. What are the implications? The implication is that now it is going to curve. So it will curve that way. Let me tilt it so that you can see. It will curve that way. The region that is growing faster, the posterior border, it will be convex, and that becomes the greater curvature of the stomach. The region that is growing slowly, that's the anterior border, it will be concave, and that becomes the lesser curvature of the stomach. So this difference in growth rate between the anterior and the posterior border of the stomach leads to formation of the lesser and the greater curvature. The anterior border becomes the lesser curvature, and the posterior border becomes the greater curvature. After that, okay, so you can see that here. This is the lesser curvature, this is a greater curvature. Or lesser curvature, greater curvature. While that is happening, the stomach undergoes rotation. There are two types of rotation that the stomach undergoes. The stomach rotates in the vertical axis or around the vertical axis, but it also rotates around the anteroposterior axis. Let's look at these two rotations and their implications. We start with rotation in the vertical axis. So rotation in the vertical axis is this. So look at is it video? Okay, look at my video, but I know if you have a phone, then you have a challenge with toggling between the slide and the video, but I know by now you've known how to survive through that. I actually don't know how you do, but for those who are able to see my video, if this is the stomach, we've assumed that it has already undergone the swelling. The anterior part grows slowly compared to the posterior parts, so it curves. After it has curved, you can see the curvature. After it has curved, we know that the greater curvature is posterior and the lesser curvature is anterior. Then we are saying the stomach rotates in the vertical axis. That rotation is about 90 degrees in the clockwise direction. And that clockwise, we are looking at the clock from above, from the top of this particular person. Otherwise, if you look at it from the bottom, it will be anti-clockwise. So I'm not indicating the direction because it will depend on how you're looking at it. It rotates this way, clockwise if you're looking at it from the top, or anti-clockwise if you're looking at it from the feet of the patient. This rotation is rotation in the vertical axis. What are the results of this rotation? Assume that stomach you're seeing in my video is actually my stomach. And so you see that 90 degrees rotation. We see the implication. One of the implications is that the greater curvature of the stomach goes to the left, while the lesser curvature goes to the right, as you can see in this image. The greater curvature goes to the left of the individual, the lesser curvature goes to the right of the individual. We can also say then, remember there was a left vagus nerve here. The left vagus nerve becomes anterior, so it becomes the anterior vagal trunk. The right vagus nerve becomes the posterior vagal trunk. In the stomach, we talk of anterior and posterior vagal trunk. We don't talk of left and right vagus nerves. In the esophagus, we talk about right and left vagus nerves because they run like that around the esophagus when they're in the thorax. But when they reach the abdomen, we talk of anterior and posterior vagal trunks. Remember, vagus nerve is the 10th cranial nerve going to the GIT. We can also talk about the implications of this rotation on the greater and lesser omentum. And I'm giving you 30 seconds to think through. What do you think are the implications of that rotation in terms of the position of the greater and lesser omentum? Think through it. I'm not going to ask you to tell me. I want you to think through it. I'll ask it to you another time. So that is it. The omentum. What are the implications of the changes? 30 seconds you do have. Okay, I want to make the 30 seconds be over. I want you to know that when the stomach is developing, the stomach is suspended by mesenteries on both sides. The anterior border has a mesentery. The posterior border also has a mesentery. The mesentery in the anterior border is called the ventral mesogastrium. The mesentery in the posterior border is called the dorsal mesogastrium. When the stomach rotates, we can see that the dorsal mesogastrium is attached to the greater curvature. So that means that the dorsal mesogastrium will go with the greater curvature to the left. And the ventral mesogastrium will go with the lesser curvature to the right. Those are the implications of the mesogastrium. In this cross-sectional image, trying to show you more details, and largely we are looking at this from the feet of the patient. The mesentery in front is the ventral mesogastrium. The mesentery behind is the dorsal mesogastrium. This is the developing stomach. I want to add two more statements that I have not said yet. Within the ventral mesogastrium, that is where we usually have the liver developing. We'll talk about that shortly. Within the dorsal mesogastrium, that's where you have the spleen developing. As the stomach rotates, where the ventral border goes to the right, so this is the right side of the patient, and the dorsal border goes to the left, it will move with the mesogastrium. So the dorsal mesogastrium goes to the left together with the spleen, and that's why the spleen is on the left of the individual. While the ventral mesogastrium goes to the right together with the liver, and that's why the liver is to the right of the patient. That's how the stomach rotates and influence the rotation of the other organs as well. What are the implications of that in the peritoneal cavity? This is the right peritoneal cavity. The right peritoneal cavity will become behind the stomach to form the lesser sac. The left peritoneal cavity will become anterior to the stomach to form the greater sac. That's why you have the greater sac and the lesser sac. The lesser sac is behind the stomach. The greater sac is in front of the stomach. All right, let's talk about rotation in the anteroposterior axis. Rotation in the anteroposterior axis is, now we are looking at the images below. This is the axis. The stomach rotates in the anteroposterior axis about 70 degrees, 60 to 70 degrees in the clockwise direction. So remember, if you can look at the video, this is the stomach. It curved, then rotated 90 degrees that way. Greater curvature to the left, lesser curvature to the right. Then the stomach rotates this way, so that the fundus, this part continues with the esophagus, goes down and to the left, while pylorus, this, what did I say? Pylorus, this part that is going to the duodenum, is going up and to the right. So the implication of anteroposterior, of rotation in the anteroposterior axis, is that the fundus goes downwards and to the left side, as we can see in this image, while the pylorus goes upwards and to the right, as we can see again in these two last images. That is stomach development. Let's make a summary of how the stomach develops. So I've told you that the site of origin is the distal part of the foregut as a dilatation. The tissues of origin, endoderm gives you epithelial lining and glands, planktic mesoderm gives you smooth muscle and connective tissue elements, while Neuro Crest gives you the enteric nerve plexus in the wall of the stomach. In terms of sequence of development, the difference in growth rate between the anterior and posterior border lead to curvature formation. Greater curvature is posterior. Then the stomach rotates in the vertical axis, so the greater curvature goes to the left. This is 90 degrees rotation. Then stomach rotates in the anteroposterior axis. The fundus of the stomach goes down and to the left, while the pylorus goes up and to the right. This is about 60 to 70 degrees rotation in the anteroposterior axis. If you are to forget rotations of the stomach and you're wondering what are the directions, try to use your left hand on your zymphy-sternum. So put your hand straight like this on your zymphy-sternum. So this part here will be pointing down and this part pointing up. That way, I can show that with my video. Okay, let me try. Okay, that way. So if you use your left hand to put it that way, then you'll be able to understand the rotations of the stomach this way. That try to make it to rotate in the vertical axis 90 degrees, and you'll realize only one direction is possible, that way. The side of the thumb represents the anterior border. It will go to the right. The side of the small finger representing posterior border will go to the left. Then try to make it rotate in the anteroposterior axis. Again, only one direction is possible, that way. The side of the pylorus, the tip of the fingers will go up and to the right, while the side of the wrist, the fundus, goes down and to the left. Remember, if you use your left hand, then that will be possible. If you use your right hand, you will confuse everything. That is what I use to remember the steps in the development of the stomach in terms of the rotations. Let's finish the story of the stomach by looking at congenital anomalies of the stomach. The commonest congenital anomaly of the stomach, and perhaps the one I would really want you to remember, and even if you forget the others, doesn't matter, is this one. We may have a very thick pylorus. So the term we use for that is hypertrophy. If the pylorus is hypertrophic, then the pyloric canal becomes very narrow. And the term we use for that is stenosis. So we call it hypertrophic pyloric stenosis. A child with hypertrophic pyloric stenosis will struggle to move gastric contents from the stomach to the duodenum. So this child will present with vomiting. Now this one vomits. If you see a newborn baby vomiting, we suspect hypertrophic pyloric stenosis. However, there's a lot of argument whether we need to classify this one as a congenital malformation. And the reason is this. When babies are born, rarely will they have this problem. Rarely will they be vomiting. They'll start vomiting about 6 to 8 weeks after birth. That's when it becomes significant. So that makes wonder, is the pyloric stenosis, is the hypertrophy really congenital, or is something that develops a few weeks after birth? There's debate about it, and as you read ahead, you'll join the debate, and you can decide on the ground. Whether congenital or not doesn't matter. The point is that a baby can have hypertrophic pyloric stenosis. It presents with vomiting. The other one that I'm showing you is the image of the stomach where the fundus is down and the pylorus is up. Remember, even if I told you that in the anteroposterior axis rotation, that the fundus goes down and to the left and the pylorus goes up and to the right, usually the fundus will still be up compared to the pylorus. As we see in this first image, the fundus is still up compared to pylorus. But in this situation where, look at the esophagus comes there, so that means this is the fundus. Then the duodenum, yeah, so this is the pylorus. So here we see the fundus down and pylorus up. This is an abnormal one. We call this gastric malrotation. It rotated abnormally, perhaps excess of the axis rotation. And so that gives you inversion of the fundus and pylorus. Gastric malrotation. There are two different types of gastric malrotation, but I think I want to keep it there. This is an abnormally rotated stomach, gastric malrotation. Okay, I think we've done another 40 minutes if I'm not wrong. Okay, we've done 50. So we'll have another last break. It is 9:22. Again, I'll give you a break up to 9:30, then we start again. But before that, if you have a question on stomach and esophagus, feel free to ask. So we'll now look at development of the intestines and the rest of the biliary system. I'm hoping that we'll now finish in the next 50 minutes without a break. So as with regard to development of the intestines, still the story of endoderm giving you epithelium and glands is standard. Splanchnic mesoderm giving you connective tissue elements and smooth muscle is standard. Neuro Crest gives you enteric nervous system. In terms of site, the intestines actually develop from all the three segments of the primordial gut, from the midgut and the hindgut. Because you say that the duodenum partially comes from the foregut and partially from the midgut. So therefore it means that intestines come from all the three segments, but mainly midgut and hindgut. A small part of the foregut gives you the intestine. That's what I mean. So what are the sequence of development of the intestines? Okay, now I'll use a longer intestine. I hope you can see that video of that very long intestine. The first thing that happens to the gut segment is rapid proliferation. It grows very fast. And because of this faster growth, there is elongation. So rapid proliferation causes elongation of the loop. I've realized this one is too long to fit in the screen. So let me use the one that was stomach. It is now the intestine. Okay, I can cut this one. So this is better. So we are saying that the segment that is supposed to be the gut, the segment that's supposed to be the intestines, grows fast, rapid proliferation. And because of this rapid proliferation, it will increase in length rapidly. Now, if something increases in length, yet this end is fixed, let's assume that is the stomach, and this end is fixed. Let's assume that's the anus. And this segment is increasing in length so fast, it will mean that this thing is going to coil. And so that coiling is what we're calling a loop. A rapid proliferation will cause elongation. And because it's elongating and the two ends are fixed, the intestine is going to form a loop. The first bend that the intestine forms is called the primary intestinal loop. Let's think through this primary intestinal loop. Remember, the midgut is still attached to the yolk sac through the Vitalin duct. That means that in as much as the loop is forming, there's something that is still holding the intestine somewhere in the middle. So the loop will not form a figure 8 kind of a loop. No. It will not be a ragged loop. It will be a nice, well-defined letter N, lowercase loop. Because of this, look at this. This segment is growing faster, so it increases in length. And because it increases in length, it will form a loop. But because the segment is still being held by the Vitalin duct, the loop will be an N like that, or like that one. This is what we call the primary intestinal loop. The primary intestinal loop can be described to have two segments. The segment near the stomach is called the cephalic limb of the midgut loop. That cephalic limb of the midgut loop represents the small intestines. Then we have the caudal limb of the midgut loop. The caudal limb of the midgut loop represents the large intestine. So that's the loop. Remember, this loop is forming in that manner because of the pull of the Vitalin duct. We have the cephalic limb that represents the midgut loop, and the caudal limb that represents the large gut. Please don't confuse the two. It's straightforward. Cephalic is on the stomach side, so that can only be the small intestine. And the caudal is towards the lower side, so that can only be the large intestine. The apex of the loop is still attached to the Vitalin duct. It is actually this Vitalin duct that's guiding the formation of the loop. That attachment of the Vitalin duct corresponds with the segment of the small intestine, specifically the distal parts of the ileum. So I don't want you to think that the apex of the loop at the junction between the ileum and the cecum. That is not true. The apex of the loop where the Vitalin duct is attached is somewhere within the ileum. That then tells you something, that there's a small part of the ileum that will then come from the caudal limb. That segment of the ileum will come from the caudal limb as opposed to the cephalic limb. But generally, the cephalic limb gives us the small gut, and the caudal limb gives us the large gut. But there's a small part of the ileum that will definitely come from the caudal limb because the apex of the loop is within the ileum, not at the junction between ileum and cecum. 3 steps I've mentioned so far: rapid proliferation, elongation, then formation of the loop. After the loop has formed, the intention is for the intestines to continue increasing in length. That's the main agenda. But that agenda is challenged by some things. At this time of development, the fetal abdominal cavity is not very big. It's not very spacious. Why? First, the fetus is small. 2, there are some large organs within the fetus at this point. The liver is very prominent at this stage because the liver is a site of formation of blood. So it's very prominent. It's taking almost half of the abdomen. Then the kidney systems are also very prominent at this stage. Remember, there are 3 kidney systems. The pronephros, there are about 7 in the neck. Mesonephros are about 40. And then the thorax and the abdomen. Very many kidneys, or kidney systems, so to speak, occupying a very large space within the fetal abdomen. So because of the large kidney system, the mesonephric ridge, and because of the developing liver, the fetal abdominal cavity is not capacious enough. What happens? The magic of embryology happens. The intestines choose to exit the abdomen. They go through the umbilicus and come out of the fetal abdomen in a sac. We call that process physiological umbilical herniation. There's a time of development when the intestines leave the abdomen. They go through the umbilicus of the fetus and up to the outside so that they can get adequate space where the intestine can continue to increase in length. That process is called physiological umbilical herniation. It occurs around the 6th week of gestation. The aim is so that the intestines can have enough space to grow outside. This journey of herniation is guided by the Vitalin duct as well. So the Vitalin duct, the Vitalin duct guides the process of umbilical herniation. I want you to remember that there's a time of development when the intestines are outside. As the intestines move out, during the process of physiological umbilical herniation, the intestines rotate about 90 degrees, the anti-clockwise direction. The rotation is around the axis of the superior mesenteric artery. That means that it's the midgut that is actually rotating largely. Now look at the intestines again. So assume this is the midgut. I'm showing a video now. Assume this is the midgut. Okay, I wish my midgut was another color, but I hope you can see it still. Now we have said that this segment grows fast, so it elongates, and that leads to formation of a loop. Okay, let me loop it. I've now looped it. You can see a loop. The upper segment of the loop is the cephalic limb, representing small gut. You can call it the cranial limb as shown in the. Then the lower one is called the caudal limb, which represents the large gut largely. As it herniates through the umbilicus, it rotates. How many degrees? 90 degrees in the anti-clockwise direction. Now I want you to see if this is representing small gut and this is representing large gut. Then the herniation process is occurring, and then we rotate. This small gut, assume this intestine is mine. So you are looking at me, this is my intestine herniating through my umbilicus. Then it rotates 90 degrees in the anti-clockwise direction. I want you to see the result of that rotation. What is the result of that rotation? The large gut goes to the left, and the small gut goes to the right. So this rotation is normally called external rotation. External rotation is 90 degrees anti-clockwise around the axis of the superior mesenteric artery. It leads to it causes the small gut to go to the right side of the abdomen or right side of the baby, and the large gut to go to the left side of the baby. Remember, that process takes place during the herniation process. So that these images show you the process of herniation and the process of the rotation. 90 degrees anti-clockwise. Small gut goes to the right, large gut goes to the left. We call it external rotation. So the aim of the herniation was for the gut to continue to develop outside. You may not believe, but the intestines stay outside the fetal abdomen for 1 whole month, from the 6th week until the 10th week of development. When the 10th week reaches, a number of things have taken place. You know, the mesonephros have now involuted. You are told they involute from around the 8th week, 9th week there. So they have now involuted. Now we have the metanephros, which is in the pelvis anyway. So there's enough space created by the absence of the mesonephros. But there's another thing. The liver is not as prominent as it was before, because now ossification has started to take place, and so blood formation is beginning in the bone marrow. Well, or even the lymph nodes are still now taking up the role of hematopoiesis. So the liver is not as much prominent as it was earlier in comparison with the size of the fetal abdomen. In those many words I'm saying, there's enough room in the abdomen. And because there's enough room in the abdomen, the intestines choose to go back. The process of going back is called hernia reduction. You can call it a reduction of the physiological hernia. When the reduction is taking place, the duodenum is the one that leads the way. The duodenum is the one that goes back first, followed by jejunum, then ileum, in that order. That is the process of hernia reduction. It explains to you why the duodenum is hidden. When you open the abdomen, you don't see the duodenum. You have to look for it, because the one that goes back to the abdomen first. During the process of hernia reduction, something happens. The intestines continue to rotate. This rotation will largely affect the large gut more than the small gut. So this image shows you the small gut that is going back, but also showing you the large gut that is now rotating. This rotation is 180 degrees in the anti-clockwise direction, and it largely affects the large gut more than the small gut. The axis of rotation is still the superior mesenteric artery. Now let's see the implication of that. So we started here, cephalic segment, caudal segment. Cephalic segment represents small gut, caudal segment represents large gut. Then herniation occurred with external rotation, large gut to the left, small gut to the right. Then there is return. During the return, there is further 180 degrees rotation. What are the implications? This large gut that went to the left during external rotation now goes up and then to the right during internal rotation. This rotation is called the internal rotation. The implication is that the large gut went to the left during external rotation, Then during internal rotation, the large gut goes up and then to the right. It explains to you why your colon is like that. From this lower end, it went to the left, external rotation 90 degrees. It went up and then to the right. This one is not yet complete because once it's complete, this one will be somewhere here. So in total, the gut rotates about 270 degrees in the anti-clockwise direction. And that one largely affects the large gut. The implication in terms of position is that the large gut goes round and so takes the peripheral portions of the abdomen, while the small gut remains central. And that's how your intestines and my intestines are. You see the large gut, the sigmoid colon is there, descending column there, transverse, then ascending column is on the right side. It's the one that completed the 260 degrees rotation. Okay. So this is showing you the concept of the rotation with almost complete, then complete rotation. It went 90 degrees anti-clockwise, large gut went to the left. Another 90, large gut goes up, then the last 90, large gut goes to the right. Small gut does not rotate all that much, and so it takes a central portion. The large gut is the one going around it. So these other images still show you the rotations, but I want to believe you've understood them. 2 rotations. External rotation, 90 degrees anti-clockwise. Internal rotation, 180 degrees anti-clockwise. Total rotation, 270 degrees anti-clockwise. Let's make a summary of intestinal development. So site of origin is the distal part of the foregut. That one only applies to a small portion for D1 and D2. Then the whole of the midgut and the whole of the hindgut gives you intestines. Tissues of origin, we have overemphasized that one. In terms of sequence, there's rapid proliferation, and that causes elongation and formation of the primary loop. The loop largely is at the level of the midgut, and so we can call the midgut loop. Then, because of space, the intestines herniate through the umbilicus. We call that physiological umbilical herniation, during which there is external rotation, 90 degrees anti-clockwise. The implication, large gut goes to the left, small gut goes to the right. Development continues within the abdomen, which means, or rather in the outside, within the sac, in the hernia sac, outside the fetal abdomen. I forgot to tell you that during that time, the Vitalin Duct is expected to involute. It disappears. Then now, the intestines go back. The process of going back is what we call hernia reduction. We begin with the duodenum sequentially. During the process of going back, there is internal rotation, a further 180 degrees rotation taking place, making the large gut to having totally rotated 270 degrees. So the large gut will then take the peripheral parts of the abdomen, and the small gut takes the central portion of the abdomen. The last step, which I didn't tell you, and I want to say it, to ensure that the intestines don't behave like this again, of this thing of leaving the abdomen and going away and coming back. You can imagine if that was to happen in you. To ensure that does not happen, the intestines must be fixed. Fixation is the last step of intestinal development. What does it mean to be fixed? To be fixed means to lose the dorsal mesentery. dorsal-mesogastrium. So the dorsal-mesentery suspend the intestines. The parts of the GIT that lose their mesentery, so they become held to the posterior abdominal wall. The parts of the intestine that lose their dorsal mesentery are the ascending colon, the descending colon, and the duodenum. Those parts of the intestine are fixed. They have lost their dorsal mesentery. They are held, they are applied to the posterior abdominal wall. The term used for gross anatomy is that they are retroperitoneal. Anything that does not have a dorsal mesentery is retroperitoneal. So these ones are retroperitoneal. As long as they're in the abdomen, they are retroperitoneal. And that's why duodenum, ascending colon, and descending colon are retroperitoneal organs. They do not have a dorsal mesentery. Okay, let's finish with the intestines by looking at congenital anomalies of the intestines. So the first one I want to highlight is the one you're seeing there, where you see intestines within a sac outside the abdomen. We call this omphalocele. Your guess will be as good as mine. This is failure of hernia reduction. So the intestines are outside through the umbilicus. Don't confuse omphalocele with gastroschisis. In as much as they're both defects of the anterior abdominal wall involving the intestines, there are some differences, and two are easy to pick even from these images, the ones I want you to remember. One of the differences that in gastroschisis, we see the intestines are not covered by a membrane. These ones are within a hernia sac. These ones are not covered by a membrane. Another difference is that gastroschisis is paramedian. Usually it is to the right of the abdomen, while omphalocele is an umbilical defect. It is through the umbilicus. Remember those key differences. Now, gastroschisis is as a result of a weakness, a defect in the anterior abdominal wall. And so the intestines are suffering because they are the organs near that defect. They just come out through that defect. Just imagine crudely that if someone was to spear your abdomen, then the intestines can pop out through that region that has been speared because the one's next there. So that is gastroschisis. It's a defect, it's a primary defect of the anterior abdominal wall, and so the intestines come out through that defect. Which means if the defect was somewhere in the thorax, maybe the lungs would the ones would have come out. This other one is not necessarily a problem of the intestines, but I like putting it here because it is closely related to development of the intestines. There are some people who have this very prominent umbilicus, even in this class, I'm sure. This is what we call umbilical hernia. It is caused by a defect in the umbilicus. Now remember, if the intestines herniated, went through the abdomen, went through the umbilicus to the hernia sac outside the abdomen, and then went back, we expect the umbilical defect to close. So if the umbilical defect does not close appropriately, then we have umbilical hernia. Defect through which abdominal organs can still be popping out and go back. Like when you laugh or when you strain, the thing bulges, and when you perhaps lying flat, relaxed, the thing goes scaphoid. You can imagine what manner of things can do. That's umbilical hernia. In this other image, we see intestines which are not in their right position. Of note is that the small gut is on the right side of this child and the large gut is on the left side in both images. Okay, there's something else being shown there which is beyond our scope. I don't think we need to think through that as a complication. But of importance anatomically, you can see the small gut is on the right and large gut is on the left. A normal one is that large gut should be peripheral and small gut central. Here, small gut is to the right and large gut to the left. We call this midgut malrotation. It is due to abnormal rotation of the midgut. The image shown on the right side shows a condition we are calling congenital aganglionic megacolon. Congenital aganglionic megacolon is a condition that develops as a result of inadequate Neuro Crest migration to the intestines. As a result, what happens? Because of this inadequate Neuro Crest migration to the intestines, there are some segments of the GIT lack innervation. The segment of the GIT that lack innervation are the distal segments of the GIT. In particular, the rectum and part of the sigmoid colon are the ones which are affected mostly. If the rectum and perhaps sigmoid colon don't have nerves, what happens when this baby feeds? The food will go all the way down, but when it reaches those segments, there is no peristalsis, so the food cannot go through those segments. Let's say the rectum. Food cannot go through the rectum because the rectum cannot experience peristaltic activity. What's the result? The segment of the gut is just above, just proximal to the part that does not have nerves. That segment will accumulate the food. And so with the time, that segment will balloon out. Remember, it's a colon, so that's why we call it megacolon. Why do we call it aganglionic? Aganglionic here refers to the fact that there's a segment, the affected segment, that does not have the nerve cells, cell bodies of neurons, ganglion. So we call it congenital because the baby is born with it. How will this one present at birth? This baby is unlikely to pass the first stool. The first stool is called meconium. They're unlikely to pass the first stool within 24 hours that is recommended. So we call that delayed meconium passage. Or they can totally not pass the stool for several days. And so that means that they're eating, but they can't pass stool, so their abdomen just distend. They'll present with obstruction. That's how they present. Congenital aganglionic megacolon is due to inadequate Neuro Crest migration. Remember, the segment that is ballooning actually has nerves. The segment that is thin is the one that does not have the nerves. You may have atresia still. And if I ever ask you, if someone ever asks you, list even 20 congenital malformations of the GIT, don't start saying, oh, that guy is bad. So many questions, how can you generate? You first thank God, then start answering. There's some 3 terms that you shouldn't forget if you're talking about any luminal organ in terms of congenital malformation. Atresia is one of them. Another one is duplication. Never forget duplication. And the third one, you can try with it also, is stenosis. Don't forget these 3 terms when you're talking about any luminal organ congenital anomalies. So if I ask you to list even 20, you can just be bright and start. Esophageal atresia, gastric atresia, duodenal atresia, jejunal atresia. List everything up to the anus. Then start again. Esophageal duplication, gastric duplication, duodenal duplication, all the way to the anus again. Then start stenosis. You can never go wrong. Atresia means lack of continuity of the lumen, tubular lumen. There are different types of atresia. You can have a septum like that. You can have a fibrous cord, or you can have complete truncation like that one. Duplication is where you have a parallel lumen. Stenosis means narrow. Okay, we may also have what we call Vitalin duct malformations. Let me take you through the Vitalin duct malformations. Vitalin duct malformations are due to persistence of the Vitalin duct. We talked about them when you're looking at fetal membranes, I think, or I hope. So one of the Vitalin duct malformations is what we call Merkel's diverticulum. That's how it presents. There's a projection. There's a part of the intestine that is coming out. A diverticulum from the ileum. Remember, Vitalin duct malformations will be related to the ileum because that is where the apex of the loop was. The Vitalin duct attaches to the ileum. Merkel's diverticulum affects the ileum. The problem with Merkel's diverticulum is that thing, the mucosa of the diverticulum, usually contain epithelium similar to the one of the stomach. Very strange. They contain gastric mucosa. And you know what gastric mucosa does? It produces hydrochloric acid. So even Merkel's diverticulum produces hydrochloric acid. You can imagine what would happen. This Merkel's diverticulum can perforate anytime. And that's why they're dangerous. If someone has Merkel's diverticulum and we suspect, we remove without thinking. Because it produces acid, and this acidity cannot be neutralized. You know, the one of the stomach can be neutralized easily in the duodenum by the pancreatic juice, the Brunner's glands, the intestinal mucosa. Here, we can't neutralize this acid, so it can cause perforation. That is Merkel's diverticulum. You can have Vitalin duct fistula, where the Vitalin duct passes throughout from the ileum to the anterior abdominal wall. You can have Vitalin duct cyst, where there is a cyst in between the two, and you can have fibrous cord. Well, there's no lumen, there's no cyst, but there's some connective tissue. These are Vitalin duct malformations still. Okay. 2 more things to go. Let me see what I'm able to do. I think I'm able to do number 5. So we are going to look at the cloaca. The cloaca is a common union of the hindgut and the allantois. The hindgut represents the digestive system. The allantois represents the urinary system. So it's a common union for stool and urine. In mammals, and you are one, the cloaca is partitioned. The structure that partitions the cloaca is called the urorectal septum. You may have talked about it already when you developed the urinary system. So urorectal septum forms in a coronal plane. It grows downwards to split the cloaca into 2. The anterior part of the cloaca becomes what you call the urogenital sinus, and the posterior part of the cloaca becomes what you call the anorectal canal. So it's the urorectal septum that grows down in a coronal plane to split the 2. Now, remember something here. We will talk about it again when you do the reproductive system. This is the cloaca. So this is the cloacal membrane. That's the cloacal membrane. Urorectal septum grows until it reaches the cloacal membrane. It makes contact with the cloacal membrane. That point where it makes contact with the cloacal membrane will form the central tendon of the perineum, or what we call the perineal body. That's the point that will form the perineal body. This region here This one here is lined by ectoderm. Remember, the blue here is ectoderm. It's lined by ectoderm. Yellow is endoderm here. This is mesoderm. So the blue is ectoderm. This region is lined by ectoderm. This part there where the pointer is called the proctodium. If it was on the upper part, you may have called it some time back stomodium for the mouth. This one is called the proctodium. That depression there is called the proctodium. Okay, so urorectal septum comes and makes contact with the cloacal membrane. Now, we have two compartments, the urogenital sinus and the anorectal canal. The urogenital sinus will give you derivatives of the urogenital system. I believe you've already talked about them. Some derivatives in the urinary system, like urinary bladder and the urethra. The others for the genital system, we'll talk about them next week when we look at part 2 of development of the reproductive system. So let me hold them for now. The anorectal canal, as the name suggests, gives you the rectum above and the anal canal below. But let me say something. The anal canal has a dual embryonic origin. The upper part of the anal canal is the one that comes from anorectal canal. The lower part of the anal canal comes from the proctodium. So this part here, look at this part. This part here, proctodium will give you the lower part of the anal canal. The upper part of the anal canal is the one that will come from anorectal canal. That means that there's a membrane, the cloacal membrane, which is now called anal membrane after the urorectal septum has reached the perineum. The cloacal membrane becomes the anal membrane for the posterior chamber. That anal membrane separates the upper part of the anal canal, the one that is coming from anorectal canal, from the lower part of the anal canal, the one that's coming from the proctodium. That membrane needs to perforate. And so, if it doesn't, you'll expect some malformations. Let's now finish with those malformations that affect the cloaca. To your left is a baby without, you can't see the anal opening. So we can call it anal atresia or imperforate anus. Could be due to failure of perforation of the anal membrane. Persistence of the anal membrane gives you imperforate anus, or you can call it anal atresia. How will this child present? They'll never pass stool, even meconium. When there is anal atresia, you may have it isolated like this one, or it may be associated with the rectum finding another channel of exiting stool, and other than through the anus. If the rectum finds another channel of exiting stool, that channel will be through the urogenital sinus. And so you may have normal communication between the rectum and the urogenital derivatives of the urogenital sinus. So those ones will give us anal atresia with a fistula. In male, you may have anal atresia, yes, with a fistula connecting rectum and the urethra. So this is anal atresia with urorectal fistula. To your right, we are seeing anal atresia, yes, but the rectum is connected to the vagina. So this is anal atresia with rectovaginal fistula. So to the right is female, to the left is male. This baby will be leaking stool through urine. This baby will be leaking stool through the vagina. anal atresia with rectovaginal fistula or with urorectal fistula. They are due to abnormalities of cloacal partitioning. The splitting of the cloaca was not okay, so there's a fistula. The extreme of cloacal malformation is what we call cloacal exstrophy, where the whole cloaca is just exposed. It is underdeveloped, it is just exposed. Cloacal exstrophy. All right. I think I'm tired. I want to stop there. It is 10:30 or a few minutes to 10:30. I will take you through embryonic origin and congenital anomalies of the hepatobiliary system next time when we meet again. About 10 slides remaining, but I'm exhausted. So I'll stop there for today and still give you a chance to ask questions if you do have. Thank you very much.